We have a saying within the myopia sort of management pocket of our profession is that, the best myopia control strategy you can do is the one that the child will wear or participate in. And so it's not about which one's best, it's about doing something rather than nothing. So, I would say, if there's a risk in the family, absolutely get your kids checked as early as possible and get them outside and off screens.
If your child is becoming more short-sighted and needing stronger glasses every year, you're certainly not alone. For a long time, myopia was viewed as something fairly straightforward. A child couldn't see clearly in the distance, they received glasses, and those glasses were updated as their prescription changed. Today, optometrists are looking at myopia very differently. They're paying much closer attention to how children's eyes grow over time, what that growth might mean to their future eye health, and whether there are ways to manage that growth process. Today, I'm with Paul Graham, owner and principal optometrist at Harmony Vision Care on the Gold Coast. We'll be discussing why myopia has become such an important topic, what modern myopia management actually involves, and what practical steps parents can take to help protect their child's future vision. For those new to the channel, my name is Paul Salloway from Optics Digital Marketing. We help eye care professionals share useful educational information with their patient communities through videos such as this one. So, Paul, good to speak with you again.
Right. Yeah, great to be back. Thank you.
So, Paul, many parents still think short-sightedness simply means their child needs glasses. Maybe some of them are even thinking, well, I wear glasses, my kids need glasses, what's the big deal? So why are optometrists paying so much more attention to myopia these days?
So a couple of factors in there is that it's on the rise in terms of just so many more kids are becoming nearsighted, and with that comes with a lot more kids becoming short-sighted, nearsighted, or myopic much earlier, and therefore their trajectory means that they're at higher risk of ending up with what we call high myopia and even very high myopia. And then what that is associated with is adult eye diseases, and fairly serious ones. So the risks increase or multiply, in fact, the more myopic you are. And we're talking things like retinal detachments, higher risk of glaucoma. In the very high myopias, we've got a much higher risk of getting certain types of macular problems. And so these are reasonably serious eye health conditions where we want to try and avoid the number of people suffering with those in their adulthood. So it's not just about the inconvenience of having to wear glasses. It's really about that future eye health.
And although you're not an ophthalmologist, I think maybe it's still in your wheelhouse can you just tell us, like, what is retinal detachment, for example? What does that actually mean?
Yeah, so the retina is the receptor layer that picks up the light. And so it's a combination. So it's made up of multiple layers of cells and nerves. And when an eye becomes short-sighted, the sclera, the white part of our eye, remodels and grows more quickly, and the retina doesn't keep up and it gets stretched. And so when it gets stretched, it can have tears and breaks. And because they're layers, it can peel away from the back of the eye, which means it's peeling away from its blood supply. And so that can be quite a serious problem. So it is a sight-threatening condition. And so the more myopic you are, the more eye stretching you have, means the higher risk you have of getting retinal detachments.
So have we learned anything about myopia in the last 10 or 20 years that has changed the way that you approach myopia and how you talk about it with parents?
Look, I guess the philosophy that I was educated on in vision and optometry meant that I've always viewed myopia being associated with near work in some way and lifestyle choices in some way. And what we have now, 20, 30 years later, is an acceptance and a whole lot of proof that those things are actually connected. And so probably the biggest thing is that we've just got a real overwhelming degree and amount of evidence now that really does support that while myopia is partly genetic and partly family inherited, there's a whole lot of lifestyle factors and choices that you make on where you do things. So, spending time outdoors versus indoors, and the intensity of near work that you do. And so it's nice to see that being proven and accepted.
Okay. Well, perhaps many parents have heard the phrase myopia management. What does it actually mean in practical terms?
Yeah, so you've got myopia correction being a pair of glasses that restores distance acuity. You've got myopia control, which is the instead of prescribing something that just allows you to see clearly, is that we're using something to attempt to slow down how quickly the myopia develops. And myopia management is the whole thing that wraps around that. You know, what's the strategy? Having a look at how quickly your prescription or your axial length is changing relative to some sort of benchmark. What myopia control strategies are available to that particular person, helping the family come to a decision on which one's going to be best for that particular situation. Does it need to be a combination? How many times are we going to reassess how things are going in terms of your prescription and length and those sorts of things? So myopia management's the whole thing put together.
So you mentioned in there about monitoring axial length. So perhaps you might want to unpack that a little bit and just explain what that means and you know how you would actually track that.
Yeah, so axial length is, so we've got the clear window on the front of our eye is the cornea. And then we've got the back of the eye where the retina and the optic nerves sort of leave the eye. And so that's the axis of the eye. So that's the axial length. So the distance between the front of the eye and the back of the eye. Now we know in myopia, what actually happens is the eyeball grows longer. Okay, so if we think of this being the front and this being the back, the eyeball grows longer. And so there's a correlation between an increase in eye length and an increase of myopic refractive error. And so as your degree or your prescription goes up, generally it means that your eye length is also going up. And the eye length is a much more reliable way of monitoring myopic growth than prescription alone.
So when you say we can't stop myopia, but we can often slow it down, are you talking about slowing down this elongation of the eyeball?
Absolutely. Yeah. And so that's the critical part is that, you know, and that's the tricky part with some patients is we might see a relatively slowing of the degree of their prescription, but we might still see that axial length is increasing at a rate that we might be a bit concerned about. And so we wanted to be monitoring both of those things. And so we have an instrument in the practice that one of its key features is it does biometry. So we use a biometer, which is part of an OCT in our practice, which is an ocular coherence tomographer. Fancy names, we just call it OCT because it's quicker and does a number of things, but we want to measure the various shapes and structures of the eyeball. And so axial length is the critical thing that we're sort of monitoring how quickly you're progressing. Now we're looking at how quickly is that axial length increasing relative to someone your age who is not short-sighted. We might be looking at how quickly is it increasing relative to another person who is also short-sighted by the same amount. And we're looking for these kind of benchmarks on trying to slow it down. We are starting to get some treatments that will significantly slow progression and put it on pause. And the trouble we've got is picking the exact individuals that's going to work best on, which is why we have a mix of tools available to us that we can kind of move and shift in between.
So you mentioned a diagnostic tool there. I think is called it an axial biometer. Is that right? And is this something that like every optometry practice would have, or only those who sort of have a particular interest in myopia management?
Yeah, so it's certainly not every practice has one at this stage. So there might be parts of the world or parts of Australia where access to some of these instruments are just not available. Doesn't stop people getting myopia management done. You only have prescription increases as your way of judging how well the treatment's working. And you can have axial length increases with less strong changes in your prescription. So anyone who's getting more serious about myopia management should have a device that measures axial length. So it is an important thing to ask that if if you're worried about myopia and you're getting serious about management, is asking the optometrist whether they refer out to get the axial length measured or whether it's something that they can get measured in the practice itself. And so either of those strategies work.
All right. Well, so what's genuinely new in myopia management in 2026? And I think maybe you're introducing a few innovative options in your own clinic.
Yeah, so we like to have the full suite of myopia management available in the practice. And so, we've got access to all the different myopia control soft contact lenses, myopia control spectacle lenses. We've been doing Ortho-K as a myopia correction and myopia control device for over 20 years now. And we've introduced a red light therapy into the practice. So low-level red light therapy is probably one of the newer ones. And what we're now getting is improvements on some designs. So version 2 of some lenses out there. So we've been lucky enough to been given early access to the MyoSmart IQ. So Hoya is a lens company that brought out the MyoSmart lens that did a pretty good job of myopia control, and they've improved the design further. And so the research has really indicated a significant reduction in the number of people who are progressing. And so we're sort of seeing, we're excited to be able to kind of see how much we might be able to slow things down even further than what we had available, even just a few years ago.
So maybe you can just briefly explain how do those myopia control lenses, spectacle lenses, like how do they work? What's the mechanism that slows down axial length progression?
Yeah, look, and most optical methods of slowing down progression work on some sort of way of doing peripheral defocus. So putting a different image shell, they call it, on the back of the eye that's different to the part of the focal length that keeps you seeing clearly. So, and what they've worked out is that if you provide a different type of defocus to the peripheral part of the retina, and if we look at the retina as just, I like to say to patients, it's a bit of brain that you point at things. And so it is registering not just whether things are clear, not just whether things are moving, but also what's the relative distribution of light. And so by altering that with these lenses, then it's switching off the signals for the eyeball to grow longer than it should. And so if you hold if someone's wearing a myopia control lens, often you can't see the lens looking any different to a regular corrective lens. But if you hold it up to the light, you'll see these little dots in the mid-peripheral part of the lens. So you've got a central area to see clearly through, and then you have these little dots that provide that peripheral defocus to sort of switch off the growth triggers at a retinal level.
Yeah, my nephew wears those spectacles, and unless you look really close, you really couldn't tell the difference between any regular pair of glasses.
Yeah. So from a cosmetic point of view, there really aren't too many issues with them. Some kids might need to just get used to those dots being there, but on the whole, the vast majority of people who wear them get used to them within a couple of weeks.
And some parents may have heard of or even have experience with the eye drops, atropine eye drops.
Atropine, yeah.
Yeah, and so maybe there are cases where you prescribe that as a standalone treatment, or perhaps more commonly as some sort of combination treatment. Do you want to just talk about that a little bit?
Yeah, look, so we've been probably a little bit more conservative around atropine, because if you use a higher concentration of atropine, the higher the concentration of atropine you use, the more side effects there are that create discomfort in terms of the pupil being big and light sensitivity and those sorts of things. And in the higher concentrations, there's a fair dropout rate. And when you look at what's available now, the once you reduce the atropine concentration down to a level that's tolerated by a majority of people, you're talking about efficacy of its ability to control myopic growth being very, very similar to what you get out of a myopia control contact lens or a myopia control pair of glasses or Ortho-K. So they're all become sort of fairly even at that particular level. So we've kind of gone, well, if you have to correct eyesight anyway, why don't we just use a myopia control lens, and then atropine becomes something that we add into someone who might still be progressing at a fairly fast rate. And that makes it more convenient because you're not having to go off and get the specially made compounded product sort of every month. And so it just simplifies things if, we're just using it as what we call an adjunct therapy.
So putting drops in your eye might help in some respect, but they're not going to help your child see the whiteboard any clearer. So they're still going to need glasses at the end of the day. At
the end of the day, and if you were somewhere where you didn't have access to good myopia control optical devices, and certainly there are surprising things like places in the US where they just don't have access this is where we're really lucky in Australia. And they just don't have the same access to myopia control optical devices like we do here. And so, they lean into needing to use atropine a lot more with just regular sort of sight correction.
So does atropine like dilate the pupil more? Is that how it works? And if so, is that potentially like exposing the back of your eye to a bit more UV?
That's where you need to be a bit more careful with using it. And so, and again, as you go up in higher doses, the bigger the pupil tends to be. You're going to get some UV protection from your lenses and your glasses, but it does mean you need to be a lot more sort of careful around, making sure you've got a hat on, using sunglasses outside, those sorts of things, not just from a comfort point of view, reducing light sensitivity, but also just, that UV risk.
Well, if you're enjoying this conversation and finding the information useful, then please do us a favor and take a moment to like the video and subscribe to the channel, because it really helps us out to produce more educational content like this and share it with the local community. So, Paul, if I'm a parent listening to this, what practical steps can I take right now to help protect my child's eyes?
So if your child has myopia or is at risk of myopia, then you need to be finding some sort of first step into getting some myopia control, not just correcting the distance vision. So there are so many things available now that really, unless you've got good proof that myopia is not progressing, then you need to be seeking out some way of managing that myopia. But from a controllable lifestyle point of view, there's very, very strong evidence that certainly for myopia prevention or delay, spending time outside more than, I think it's like 14 hours a week, so we're looking at 90 minutes to 2 hours a day outside, is protective. And it doesn't mean that your child won't become short-sighted, but the link is that it tends to delay the onset. And the longer we can delay the onset, the less short-sighted and the lower the speed that a child becomes short-sighted if they do eventually start that way. And then also minimising intense near work, trying to reduce down any unnecessary use of devices and screens, and, getting the kids to start taking breaks, sort of every 45 minutes they need to get up and take a decent 5 or 10 minute break. And as we've discussed before on various visual hygiene things, a break from one device doesn't mean you go and pick up a phone or move to another device. It means, getting out and moving and using your vision for what it's really designed for, and that's moving through the world. And the more time you can get outside in green space.
My son was in junior high school a year or two ago, and the school's like literally just around the corner, so he could get there like in a couple of minutes. But now he's going to a high school where he actually has to walk like 30 minutes to get there, 30 minutes back. And I think that's great from a number of different aspects, one of which is like, he's actually getting out there and moving through the world. Look,
I think there's a lot to be said about incidental kind of things like that. I mean, from an exercise point of view, I remember one of my early jobs, I was working in a more retail practice, and we were in a large shopping centre, and there were certainly escalators and lifts and those sorts of things available to get from the car park to work, but I would purposely not take them and, take the stairs and not necessarily try and chase down the closest park to where I work to get that incidental exercise. And I'm sure if families put their mind to it, there would be lots of other incidental ways where you can get outside more often. I mean, it doesn't have to be, you don't have to be someone who's doing these amazing physical feats outside. You just need to be outside moving around away from devices.
And if you walk into school with your kids, that's good parent-child time as well. So lots of benefits.
Yeah, absolutely.
So what should parents expect from a modern myopia-focused eye examination at Harmony Vision Care?
So a good case history, finding out what the kids are into, finding out family history. So trying to work out, how many parents in particular and siblings might already be short-sighted, because your risk factors for developing short sight certainly increase with the more family members you have who are also short-sighted. So finding out those sorts of things. So if parents can come in armed with their own prescriptions, that's very, very useful. And, we ask questions around their interests. If a child, is into, high-level soccer and they're training 6 days a week, well, that's a great sign from a protection point of view, versus a child who has no interest in sport and doing lots of screens. So we want to kind of know what sort of lifestyle influences are going on there. And then we go into the sort of case history of finding out how well they see the board and all of those sorts of things. Even though we are focusing on refractive error, so the degree of myopia, we also do want to know a lot about binocular vision. So convergence and focusing is still an important part of managing myopia, because there is an association of certain types of binocular vision issues that may influence the kind of treatments that you might decide on. And then if we have a patient who is at high risk of developing myopia or is already myopic, then we want to be doing that axial length measurement or biometry to have that as our kind of gold standard, as they call it, for monitoring progression. And so I think that's the field that part of myopia strategy that I think will be the future, is really getting into identifying those kids who are at high risk before they even become myopic, and having some evidence-based strategies that we can use to try and slow things down when they're at high risk. And so having that body of information like axial lengths and things like that is a very, very important part of all of that.
I speak with some optometrists who deal with dry eye disease management, and what some of them have told me is that AI is also becoming a very useful tool for the diagnostics of that particular ailment. So I'm just thinking, maybe like as technology advances, maybe AI and similar sort of technologies may help more and more every year with myopia management.
And that's the thing. Both dry eye and myopia have a huge amount of research being done, and some overwhelming amount of research that's being done. And yes, we look forward to things like tools and calculators where you can say, okay, this is the person's eye length, this is their corneal curvature, this is the number of hours a day they do X, this is the number of hours they do Y, this is how many parents and siblings have it. And we've got sort of fairly basic calculators for that now that kind of help you work out is someone at low risk, medium risk, high risk, those sorts of things. So AI is going to make that a lot more nuanced and hopefully a bit more sort of targeted, particularly, like I said, when we get into that whole predicting future myopia risk in kids.
Okay, Paul. Well, if there's one thing that you'd like parents to remember about myopia and their child's future eye health, what would it be?
Look, we have a saying within the myopia sort of management pocket of our profession, is that the best myopia control strategy you can do is the one that the child will wear or participate in. And so it's not about which one's best, it's about doing something rather than nothing. So, I would say, if there's a risk in the family, absolutely get your kids checked as early as possible and get them outside and off screens. They're the two things.
Okay. Great, insightful information as always. So for parents on the Gold Coast who would like to learn more about myopia management or arrange a myopia-focused eye examination for their son or daughter, how can they get in touch with Harmony Vision Care?
So harmonyvisioncare.com.au. So we've got a wealth of information on there. You can book online. You'll find our phone number there, which is 0755205900 if you need to talk to one of the team members. And obviously we're on socials, YouTube, Facebook, etc.
And if you found this conversation helpful, then don't forget, please like the video, subscribe to the channel so you'll be notified when Paul releases more videos like this one, and share it with a parent who might be concerned about their child's vision or changing prescription. Okay, well, thanks for watching, everyone, and we'll see you next time. Bye, Paul.
Thanks again.